Welcome to part 3. We will be discussing healthcare delivery systems, leadership, and delegation. Healthcare is a very broad term. There are a lot of places and people who are part of healthcare, so this part will discuss all of these. When we discuss healthcare delivery systems, we need to look at the 3 levels of healthcare. The first level is primary healthcare. Primary healthcare settings are settings where the focus is on prevention and treatment of common health problems. These settings include primary care centers, urgent cares, employment health centers, and they're typically managed by family practice or primary care providers and nurse practitioners. The focus is on health and wellness, immunizations, education, and common health problems that do not require higher levels of care. The second level is secondary health care. These settings focus on diseases that need more specialized care, such as hospitals, emergency departments, and same-day surgery centers. The providers in these areas are typically specialists or nurse practitioners who specialize in one area, such as cardiology or obstetrics. Tertiary health cares are settings that take it up a notch. They manage rare or complex disorders and are typically managed by specialists who are specialized again, like cardiovascular surgeons, pediatricians, oncologists. These facilities are usually very large teaching hospitals like Mayo Clinic, Cleveland Clinic, Banner Heart Hospital, Phoenix Children's, and City of Hope. Although some secondary healthcare settings may have departments that are specialized and broader, tertiary care like Banner Boswell's Heart Center and Banner Thunderbird Pediatric Department. The 3 levels of healthcare encompass so much more than what I just mentioned. Healthcare has hospitals, primary care centers, ambulatory care centers, home health, extended care like long-term care centers, specialty care centers, mental health, and hospice. In addition, there's telehealth, where people don't even need to leave their homes to get care, either by phone or Zoom. But there are lesser known healthcare settings like prisons, churches, schools, adult daycare, homeless shelters, occupational centers like car manufacturers, med spas, and community centers. This is going to be the 3rd time I say this. Nursing is awesome because we have so many places we can work. We can work as a nurse for 40 years and never set foot in a hospital after we graduate. Healthcare is comprised of macrosystems and microsystems. Block 1 focuses on microsystems. So what is a microsystem? It's a small functional unit within a larger system. I like to think of it as the intensive care unit in a hospital. Okay? The ICU is a small functional unit of the greater hospital. It has its own specialized nursing staff, its own providers or medical staff, and its own ancillary personnel. All of these roles work together as a team to care for the patients. These microsystems could not function without the interprofessional or interdisciplinary team. Interprofessional or interdisciplinary teams are made up of different healthcare members with the shared goal of delivering the best practices to the patient. Sometimes, especially in pediatrics, the family members are even part of this team. Every member of the healthcare team has shared common competencies, aside from the competencies set by their profession. Their values and ethics are similar. We're all there for the patient. The roles and responsibilities are clearly defined and accepted. There is open and honest communication, and there is teamwork. For the ICU example, my background is open heart surgery. I worked in the CV ICU. I took care of patients directly from the operating room after having open heart surgery. My interprofessional team was my fellow nurses, which included the operating room nurses, the respiratory therapist, our on-unit pharmacist, the surgeon, the cardiologist, physical therapy, occupational therapy, housekeeping, and dietary. I could not do my job as a nurse without all of those people. All of those people came together to provide the patient-centered care. And I just want you to remember that there are a lot of places that nurses can function in a hospital besides just being at the bedside. We can be the direct care providers at the bedside. We can be managers of other members of healthcare teams. We can be administrators. We can be nurse practitioners. We can be clinical nurse specialists. We can be the patient educator. We can be the in-service educator, or we can be a researcher. So there's so many things we can do in a hospital that is not providing direct patient care, and I want you guys to remember that. Like I just mentioned, that there's so many people who are on that interprofessional team. So some more people. We have us, the nurses. We have licensed practical nurses. We have nursing assisted personnel, or NAP, or sometimes you'll see it as UAP. We have advanced practice nurses. We have the healthcare provider, which could be the physician, could be a physician's assistant or a nurse practitioner. We have pharmacists. We have respiratory therapists, dietitians, physical therapists, occupational therapists, speech therapists. We have case managers, social workers. We have technologists like lab techs and radiology technicians, spiritual services and interpreters. And all of these roles have one common theme, and that is person-centered care. We're now going to switch roles, and we're going to take a look at leadership. Leadership comes in many different forms depending on the setting. A leader for Ford Motor Company is going to function very differently than a nurse manager. A nurse manager is going to function differently than a relief charge nurse. That being said, all of these leaders have something in common. They have the ability to motivate and influence people to achieve their goals. There are different leadership styles. Some are better than others, but you will focus on those in later blocks. There are two different types of leaders in healthcare. One is an explicit leader, someone who is empowered by virtue of their position. This would be people like charge nurses, nurse managers, directors, chief nursing officers. We often call them formal leaders. The other type of leader is an implied leader. Those are those natural born leaders. Their personalities get people to follow them. We often call these people informal leaders. Their presence and their personality lead without an official role. We need these informal leaders to help make change in healthcare because they are the people most likely to tell the formal leaders what change is needed and why. This slide is going to focus on the positive attributes of being a leader. There are so many qualities someone needs to be an effective leader. The leader needs to be charismatic and enthusiastic. Those who are contagious and tend to make the staff act the same way. Leaders need to be confident, yet empathetic and caring. They need to be self-directed and flexible, but also need to be committed to their role and to excellence. Leaders need to be knowledgeable in their area so they can use their problem-solving skills to fix the issues that may arise. Leaders also need to be trustworthy, accessible, and respectful. Leaders should also encourage their staff to grow and learn and to move up the ladder, so to speak. Good leaders build up their staff. Nurse managers have several roles they need to fill during the day. As a new grad, I did not realize all the roles they filled until I was completing my BSN and I needed to spend some time with a nurse manager. I chose to spend time with my nurse manager, and oh my, were my eyes opened. My view of her role as a new grad was to make staffing as tight as possible. In addition to staffing, she was planning schedules for the next month, organizing supplies and medical providers, directing admissions and surgeries, and really controlling the chaos that came with a 40-bed med-surg unit. In addition to these roles, nurse managers need to be able to work collaboratively with everybody on the healthcare team. Now, my BSN was right around the time when evidence-based practice was gaining popularity in hospitals, so I didn't get to see that aspect of leading and leadership in action, but I had plenty of nurse managers who afterwards were very dedicated to evidence-based practice. We're going to switch gears a little bit and look at the ways that nurses who are not in leadership roles act as leaders, and that's with delegation and supervision. Supervision in relation to nursing is about the RN working with and delegating tasks to the assistive personnel and supervising them to ensure that it was done correctly. Nurses have the ultimate responsibility for the patient, so if the assistant personnel doesn't complete a task or does it incorrectly, the nurse must fix the issue. One thing I always tell nurses, especially new grads, is that a tech will make you or break you. Treat your techs with dignity and respect, and don't make them do every single thing if you're capable of doing it. I once watched a nurse walk around the entire unit looking for a tech to fill up the water pitcher that was in the nurse's hands instead of filling it up for herself. Nurses need to remember that APs are there to support us, not for us to walk all over. APs should be given a report on each patient so they know what's going on. They should be updated on any changes during the shift and should be treated as your right-hand man. And if you are currently a tech and you don't get this from your nurses, you need to ask for it. The RN is responsible for the patient assessment, discharge planning, health education, care planning, triage, interpretation of patient data, care of invasive lines, and administering medication. Aside from these things, the scope and practice of your AP dictates what they can and cannot do, as well as the policies from your facility. Those policies may be different unit from unit as well. You must know what they can do before you can delegate to them. The RN can delegate tasks such as assistance with basic care activities, collecting patient data such as vital signs, sometimes simple dressing changes, transfers, and postmortem care. Before delegation, the nurse needs to assess the stability of the patient. Are they doing okay, or are they trying to die? How complex is the activity you're trying to delegate? Can they complete it, or is it going to take them hours? Could the AP cause any harm doing the activity you're delegating? Is the activity going to take the AP away from other patient care that is needed? I mention these things because a unit I worked on as a tech had 40 beds and we were always full. We had a patient who needed a major dressing change, but it took 3 people to roll him and keep him turned. That took half the techs off the floor for an hour-long dressing change. Every time we had to do the dressing change, the unit would go insane because no one was out there to answer the phone or the call bells. We also need to look at the 5 rights of delegation when we decide to delegate a task. Is it the right task? Is it something that can or should be delegated? Is it the right circumstance? If I delegate this, what won't be able to be completed? Is it the right person? Is this tech able to do the task? Right directions and communication. Am I able to communicate the directions effectively? Right supervision and evaluation. Can I supervise and evaluate the task after it's completed? This one is extra special. If I delegate vital signs, I must go back and evaluate the vital signs to see if any intervention on my part is needed. This is the end of part 3. Please move on to part 4.